Good morning. Can everybody hear me okay? I want to start actually by thanking the Institute of Medicine for allowing my team and I to write this paper and collect the information. And my team is here, so I want to introduce them. First, Catherine Barrett-Ryan, who probably can't stand up at the moment. Want to stand up? There we go. And Ima Rouhani, who's sitting next to her. And I'd also like to thank the various experts that we interviewed for this, plus a couple other graduate students who helped us write this paper. And actually, I'm very humbled to stand before you because to me, all of you are the experts on informed consent and health literacy. And almost to a person, you are cited in this paper. So I want to also thank everybody here for doing the kind of research that we can cite and summarize and learn from. And with that, let me start with a few pieces of information that you probably already know. Let me see how this works. Okay. So as we all know, as we work with people with low health literacy are more likely to give uninformed consent, refuse beneficial medical treatments, and drop out of clinical trials. And a very well-known video that a lot of us have seen, I think, illustrates this for me very well.
I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
So to me, this sort of illustrates in a very personal way the problem that we're discussing today. But this problem has actually been around, for decades. These are titles of articles that we found. 1972, Informed but Uneducated Consent. 1981, How Informed is Informed Consent? Informed Consent, Is It a Myth? 1992. Consent Documents for Oncology Trials. Does anybody read these things? 2004. And Improving the Quality of Informed Consent. It is not all about the risks. The body of knowledge on informed consent and health literacy is actually quite massive. And much of this literature, authors struggle to create better communication for purposes of informed consent within the constraints of the federal regulations that Dr. Sugarman referred to. Federal regulations often interfere with our ability to create health-literate informed consent. So with all of this research and all of the recommendations done over the decades, what can a commissioned paper for the Institute of Medicine actually add to this body of knowledge? We conducted a systematic literature review and some key in-depth interviews to find out, and we believe that our paper achieved 3 goals. After our literature review and interviews, we found over the last decade of research support for a set of best practices and lessons learned. We identified gaps to create a future research agenda, and we created 2 models of health-literate informed consent. Unfortunately, with the limited time we have today, I can't go into all the details of the method and all the aspects and information that we found, but please feel free to ask questions when we're done today. but I'm going to summarize some of the best practices in the two models that we developed. There were a number of trends in the informed consent procedures literature and health literacy literature that we found. Overall, as Dr. Sugarman also referred to, we found more patient-centered approaches, increased empowered and active decision-making for clinical trials, and the increased use of technology to streamline the process and improve patient and participant understanding. Overall, a lot of authors over the last decade talk about meaningful consent as opposed to or in addition to informed consent. An example of a technological system that has been used by MITRIS. Has anybody heard of Enroll? Raise your hand. So I want to show you really quickly a brief minute of what MITRIS has done to use new technology and informed consent.
The purpose of the informed consent document is to properly educate patients so they can decide whether or not to take part in your research study. The problem is, once all the organizational requirements are baked into the document, the language can become confusing and difficult for patients to understand. Eager to participate, some patients may still sign on the dotted line, even though they don't fully understand what participation in the study really means. This can be costly to the study sponsor, as the patient requires more instruction, longer consultations, and ultimately may decide to leave partway through. At MITRIS, we think there's a better way. We've created an electronic informed consent learning tool called Enroll that places patients at the center of an interactive consent process, with tools that measure their understanding of the risks and benefits of participation. Better understanding leads to a stronger commitment, so patients are more likely to complete the research study. In fact, an independent study showed superior comprehension recall when comparing a paper-informed consent document with the Enroll electronic informed consent. Patients aren't the only ones better informed. By digitizing the process, MITRIS puts identified information at the site's fingertips and de-identified data at the sponsor's fingertips. Real-time access to patient consent and enrollment data, feedback directly from the patients, and critical study metrics empower you to make the refinements you need to streamline patient enrollment, increase comprehension, and ensure a successful trial.
We're not suggesting that MITRIS's program Enroll is a best practice, but we wanted to offer an example in case you haven't seen what they're doing these days with the new technology that's available. We, in our paper, actually summarized 30 of the top best practices, and I'm going to offer just a few of those now. So first of all, again, what Dr. Sugarman referred to is recognizing the importance of time. In many cases, informed consent is done actually when the patient or participant is right there or with only a few minutes to spare before procedures are about to occur. And research has shown that the longer the time that a patient or participant has to consider the documents, the information, ask questions, sometimes maybe a week or two ahead of time, then they come in better prepared to make a decision. A lot of researchers today are considering the level of risk in the clinical trial or the surgery to decide how much information to put into the informed consent documents. So instead of taking the federal regulations and putting all necessary information into the documents, if it's minimal risk, let's look at what information is needed. And ARC actually has a wonderful template for informed consent forms based on minimal risks research. Viewing others as part of the decision making, looking at cultural and language differences. A lot of times in other cultures, people want to bring their family members or other people with them, and to be open to this idea of group decision making or family decision making when it comes to informed consent is a new way of doing informed consent. Something we probably already know, 8th grade or below reading level for the documents, although time and time again, there's evidence that documents are over high school level reading. And of course, using teach back and teach to goal. Not only asking participants to recite back to you right there if what they learned or how they're interpreting this, but to continue to do that verbally until they understand each piece of the informed consent procedure. One example of a best practice that we heard from an interviewee is where the researcher gathers groups of participants together and combines PowerPoint and interactive PowerPoint training on what is informed consent, not just what you will be doing in this process. So lecture, PowerPoint, and then getting questions and answer time in, and then allowing the group to discuss it, and then proceeding with having them sign individually. They had extremely low dropout rate, and nobody dropped out in the middle of the study. There are several comprehensive toolkits, resources, and templates for informed consent that you can find on the web from AHRQ, from National Cancer Institute, from the FDA, and also from nonprofit organizations. And those are listed in the commissioned paper. One area of, sorry, that's backwards there. One area of a lot of research over the last decade is on multimedia and online approaches. The findings on multimedia and online approaches to conducting informed consent procedures are mixed. There are a lot of pros, but also a lot of cons that researchers have found about using new technology to try to increase informed decision-making and understanding. On the pro side, authors have found that the approaches using internet-based interactive tools and also video and audio create a more user-centered environment where the participant has more control over the situation. The researcher has found that it offers more consistency across the different individuals in the study. It allows for an audit trail. They have found that it lowers anxiety among participants, and it reduces staff time and costs. On the con side, again, there's mixed findings, so every situation seems to be different, and you need to consider the different factors, such as low health literacy. Research on low health literacy has really not yet found solid evidence that alternative formats beyond verbal and written has been very effective. It's been dependent on education level, age, and computer experience if you're using online technology. Some researchers have suggested that in the absence of consistent findings, the format to use should depend on, for example, again, level of risk in the study. If it's minimal risk, you may be able to use different formats that are appropriate for the audience. If it's high risk, you may need to combine written and oral with multimedia. The best practices and lessons learned support findings from earlier decades. Plus, in the last 10 years, there's been a lot of research, as I said, focused on new technology and ways it might help. But there were also gaps in the body of knowledge, which led us to develop a couple of models. And if you want, I can go over the gaps later during question and answer, but right now I'm going to focus on the two models that we developed. We like to view these as prototypes. In other words, visualizations that really require dialogue, revision, empirical testing, and perhaps they don't work beyond the literature review that helped us bring this together. We think that they fill some gaps in research that we found, and the models that we developed are based on the universal precautions approach to health literacy and a situational communication framework where the context depends. Okay, so the first one is the roadmap to health literate informed consent. This is a step-by-step visualization of the sequential order of larger process phases to complete in order to reach patient understanding, regardless of level of health literacy. So this is based in the universal precautions approach where we're assuming the target participants have low health literacy. Each step builds on the one before and embeds best practices that we found in the expertise and research that we gathered. Now, given that the last two slides didn't work out so well visually, we'll see if the graphics on this one works. Okay, the arrow worked. That's good. So the first step is to know your setting and know the risks. This includes practitioner characteristics, such as training of the people who are giving informed consent. So there you go. The arrows didn't work. I got one up there. It's important to be flexible. So number 2 is to train your staff. This is around the area of informed consent, not just the study details. 3rd is to know your participants. Cultural differences, literacy differences, age, technological skills. 4th, simplify written forms. I don't have to tell you, we already know about this. The language used, the reading level, and everything else that we've been learning about last 40 years. Number 5, consider alternative formats, multimedia, etc., depending on the situational factors. 6, dialogue. We have found that verbal exchange is still core to increasing understanding and informed decision-making among participants and patients. 7, assess comprehension using teach back and teach to goal. And 8, assess the actual system that you used. So to improve the process every time, go back and see what worked and what didn't work in the informed consent process that you used. Now it works. All right, the second model is the situational risk model for communicating informed consent. So this incorporates a more tailored approach to communicating with different audiences based on level of risk in the study. This takes the ARC template and other templates that we have found based on minimal risk or high risk and tries to put them together in a model. So you'll see on the left-hand side, as the risk goes up from community-based surveys all the way to high-risk surgeries, high-risk clinical trials, you add more information in the informed consent documents. So ultimately, you will always include benefits, possible risks, purposes and procedures, voluntariness, and confidentiality. But as the risk goes up, then you would also include additional details on the right to refuse or discontinue, common side effects, alternative treatments, and post-surgery plans. So ultimately, some suggestions that we found were very simple. Spend more time, meet with participants, use clear language. Others were more complicated. One study, for example, developed computer avatars that teach participants about decision-making and informed consent. But what was surprising to us was that even with an accumulation of all of this information, there continues to be barriers to informed consent. Authors continue to talk about the restrictive federal guidelines and how challenging it is to reach meaningful informed consent. What we hope is that our paper and the dialogue today will increase meaningful dialogue about this and seek ways to better improve communication and health literacy during the informed consent process. Thank you.